Hello, hello everyone. Thank you so much for joining us today. So we have a nice case. ¿Cuántos años tiene la señora? This is a 62 years old woman with a history of jaundice and also abdominal pain, important abdominal pain. But there is also lose weight. This patient, I believe, have liver cirrhosis because of MASLD, to be honest. But what we found is gallbladder that is completely irregular and hypoechogenic areas of the wall, more suggestive of malignancy. So there is this doubt right now. So I want to make the right approach that we need to do it. So now I am doing at US, but here at 25 centimeters, I see in the mediastinal this lymph node. You can see here very well, big lymph node. So I will start making a biopsy here. This is very important. Take the tissue. You know, tissue is the issue. The American people say that, right? And they are right in general terms. And it means we cannot under evaluate any of the lymph nodes or whatever, because we know that because of the shape, probably this is inflammatory. But I have a patient with a suspicion of cancer, so I don't care. Classifications are fine, the characteristics are fine, but it doesn't mean that it's 100% perfect. You know, so there are exceptions sometimes. So that's why it's very important, in my opinion, right, to make the biopsies when it is needed. Okay, so in this case I prefer to make biopsies because I want a perfect diagnosis. Sometimes I am a little, how to say it, obsessive compulsive. So now I have here, so this is my needle. I am using today a Microtech endoscopy needle, 22 gauge. This is the core needle, right? So you see, I like it because the quality of the image is very good. I want to say hello to my good friend Chris Lee and all the team of Microtech from China. Scott, also thank you. One big hug. So I'm using now the needle for taking these biopsies from this lymph node. Okay. So even if this is a FMB and many people love to do it in different way, they say no, no suction. I prefer to make suction, to be honest. This is my technique. I'm not so sure if fanning technique is amazing. Probably yes. I'm not very good for all these, uh, different opinion and different studies. I'm not so good for no suction FMB, and many people also prefer to just to do two passes, for example, and not too much. I prefer to make one pass with many passes, so in that way I can have a very good result. However, this is just experience. It's not about, to me, or rentability of FMB is 92%, which is good. But it increases when you take from different areas, that is for sure. So now I will see that, and then I will go down because I need to evaluate everything. So we have super nice news for the next months. ¿Cómo vamos? ¿Ay? ¿Ay? Oh, yes. So, I don't know if it's the needle, I don't know if it's the endoscopist. ¿Tú qué piensas? ¿El endoscopista o la aguja? is the two things, say my fellow from Peru. ¿Cómo es tu nombre? Paul. You can see here the quality of tissue. A ver, ayúdame aquí. Oh. Look. Very good core tissue. I don't have too much blood, you see? Almost nothing. So it's a very good quality of needle, you see? Right? So and well, it's not because of the brand. I believe it takes in account also the maneuver that you do it. But well, I will continue. I want to see if there is a spine. This is the aorta. I'm sorry. I will diminish my window right now. I will try to see if there is any other, lymph nodes. This is the lymph node of the sub. You see here. So this lymph node was the most important that I have to take it. And now I will go down. I'm not looking anything, but look, this liver. This is a complete liver cirrhosis for sure. And I'm not so sure. You see here there are some ascites. So when you have this and the possibility of a cancer, maybe this patient is not just cirrhosis. I believe this is probably an advanced, gallbladder cancer, if there is, right? But this is ascites. You see here ascites, a small amount of ascites. You see here, a small amount, really small. So I don't know if this patient no tiene dolor, ¿verdad? No pain, but you see ascites here. You see? So this is important, right? Because I need to see cómo están los parámetros albúmina y todo eso. So this could be because of the liver cirrhosis, but also we need to take some samples from here, just from the liquid. I prefer to take it just to send to evaluate if there is cancer cells in the liquid, but I will take it after. There is some lymph nodes, a lot of lymph nodes here. You see here, right? We need to take biopsy from these ones also. So I will take biopsies from these ones. Let's see the elastography here. It doesn't look hard, right? But as I mentioned to you, it's better to take biopsies. So in that way you can have probably a better result. So I will take my second biopsy. This is from the lymph node, the biggest one that is here. Just near to the liver. 60 millimeter, you see? It's big. It's not short. Again. Oh, not perfect. So now I am inside, I believe. Now I am inside, yes. You can feel it. And don't be worried, because sometimes we have some fear about if we can make a. So I try to pass from to cross the whole lesion, to be honest, right? From one side to the other side, and I need to see the needle passing, because if not, you are not taking a good sample. This is my, just my, how can I say it? My tip and my trick, right? You see, I keep my position and continue doing that. The needle looks very well. Perfect. Okay, now. So I will see if I have something. As I mentioned to you, I always prefer to pass a lot of pass, and to have very good stakes, like that one that I show it. And I will continue. So then, so we saw the liver. I see it now. There is a lot of lymph nodes in this area. You can see here, 1, 2, 3, 4 different size. And I want to see now my pancreas, because this is very important, right? Okay, this is collateral vessels. So here we have the celiac trunk. This is the aorta. I follow the aorta. So the celiac trunk is here, the splenic, and then I can see now my pancreas. So the pancreas looks well. The main pancreatic duct is okay, and this is the splenic vessel, I believe. Yes, splenic vein is little augmented, but this is because of I believe there is a portal hypertension for sure. There's still ascites here. You see here, the pancreas looks very well. So the body of the pancreas is okay. The tail of the pancreas looks well, and then we have the spleen just over here. Okay, perfect. So now I will advance a little bit more so I can continue to see my ascites. This is the way that we need to do it, huh? This is the way that we need to do it. We need to evaluate everything, you see? Look, another lymph node here, big lymph nodes. I want to see here. So Raquelita told me already that there is something. So I think this is I can differentiate. I need to see very well. Look, this mass here. This is the gallbladder, right? I think, yeah. So, and I want to move just to see if this is, no, this is solid. Okay. Let me see the elastography. You see, it's different, huh? So it looks like a solid lesion, hard tissue, it appears, at least by the gray scale that use, the elastography. But we have other techniques that we can use it. The strain histogram is the mean is 52, so it's hard. It's on the board in the border, but you know this is not like very hard like normal, you know, pancreatic cancer, for example. So this is very important. And now I'm using, you see, this is the share wave technology. You see, it's hard. 31 and 40 mean 19 is very hard tissue, so give me the needle. So I will make a biopsy from here, but also I need to make an ERCP now because she have done this, and I will pass a colonoscope. I want to see inside, and this is what we need to do it. So many people just do the US and biopsy, but if I will pass, you know, and I will do a complete evaluation, I need to make a good evaluation. You know, it's like the surgeon. The surgeon doesn't go inside the abdominal cavity and then they say, no, I will take just a biopsy from the gallbladder, I will not see anything. We need to see if there is any carcinomatosis, how is the extension of the lesion, a lot of things. So now I am inside. I believe I need to go in this area. This is how one simple technology like EUS can make a complete diagnosis much better than CT scan and MRI. So we can see a lot of small things, and we have the advantage that we can take a biopsy immediately during the procedure, as you can see here. You see? I didn't do like a funny technique or something like that because I am not so good for that. I'm trying to change the position sometimes, but it's okay. The important is to have a good tissue. So in these cases you can use also a Murray biopsy forceps if the quality of the tissue is not good. It will depend, but well, let's see what is going on. Okay. So I think I have a chance to go with the cystic duct because this is a cystic duct. It's big. I think I can go inside and see from inside. Let's see if I can do something. Okay, I will see the head of the pancreas. Let's see what is that. This is another lymph node, huh? Yeah. Okay, so now another lymph node. So this is very suspicious for cancer also. So dame para tomar biopsia de este linfonodo. So let's see the elastography of the lymph nodes. This is more hard tissue, it's more round. I will take biopsy from this one. So that's why I said to you, you need to make a very good evaluation always. Is the best. ¿Tienes otra aguja? Sí. So it's better to do not use the same needle in this case, because I didn't sew it this one. So it's better to make the punction with another needle. Okay. Lo que quieras. 25 puede ser. ¿Tienes 25? Dame una 25. So I will take 125. You know why? One, because of the position. Second, it's very difficult, this lesion. Huh? But I need to take the biopsy from this one. This is important. Okay, so sí, sí está bien. So I will use one Boston. It's not my preferred one right now because I believe a lot of needle had made a lot of improve in terms of technically, in terms of quality. So and it's very important that the companies always improve. They need to improve, because if not, so well. ¿Qué hubo? Ya está la aguja. So now I have the needle inside. So many people ask me, when do you use 25 gauge needle? Normally I don't use too much. I use when the lesions are very small, in the pancreas for example. So in those cases I use it. And when we are in the third portion, right, like this one, when it's difficult to have an access, you know. Okay, so now. So one of the things that I don't like it, let's say like that, is this. You need to improve this. A lot of companies improve this. No, it's okay, está bien. Estoy diciendo que no me gusta, ¿no? It's a lot of, it's too much. So then you have to make a good position. And then go with your needle. You see why the 25 is nice? Is because you don't have to make a big deal or a big. I am using a standard needle, huh? We can have core also with a standard needle, huh? So this is something that nobody says, but I can say. Apply the same technique and you will see it. So now I am passing the whole, you see? You see? Very good. Now I have a very good control of my needle. I am not having a lot of risky. My endoscope is not suffering. My needle is not suffering. And my patient is not suffering. I am just taking the biopsy, but this lymph node is very important. This you can less pass. Normally with 2 or 3 is okay, but but this one I believe is special because it's round, it's hypoechogenic, it's very round, the shape is uniform, so I believe this could be a lymph node with malignancy. So the elastography also showed it blue, so there is a lot of information that we have, lot of data of this lymph node. So now it's okay. I give this. Okay, so now I will change my tube. I will use one duodenoscope. Another lymph node here. It's rare, but well, let's move forward. ¿Todo bien? Okay, so this is the quality. It's not bad. You see, we have a core. I don't know if I can see well. So as I mentioned, it's not just, you see there, huh? Even with 25 gauge needle, you see here, I have very good core tissue. It's a 25 and standard. So yeah, the FMB is good, but I believe also is the technique. So now I will pass my duodenoscope. Okay, so now so this is a super nice case, I believe. ¿Ah? Tenemos colangioscopio de 6.5. Bueno. Y tenemos el de 7.5, me parece que tengo por ahí, ¿no? So maybe I will use one new tool. Ajá. Opa. Fluoroscopía. Brian, la fluoroscopía. Okay, so that's the pancreas. We are in a diverticulum area. So I will change my position a little bit. So many people can ask me also, why do you inject? I don't like to be blind. to be honest. And there is a lot of studies that show it that the problem is not the contrast. The problem is the manipulation of the ampulla more than 10 minutes. That's the problem. Okay, so now I will go inside here. So I am in the pancreas now. Tonight. Okay. No des rayos. ¿Tú estás dando rayos? Ya. Separa el rayos X. Okay, I will less there. I think there is a... Dame, empuja. I think there is a pancreas division here. It's okay. And I will make a double guide wire technique to make my cannulation. La otra guía. No. Dame... Ok, dame floro. Dame floro tú. So I'm trying to look in where is my berry tract. But it's becoming a little difficult, huh? I think maybe it's there. Okay, now we have. ¿Me le puedes hacer zoom? Dame tu floro porque no sé si el pedal no está funcionando. Floro. Floro. No. Floro. ¿Y qué pasa? Okay, you see, I make a small change in my tip, looking for make the cannulation. You see, I arrange the tip of the scope. So I will remove this. I will not less anything. I will just inject right now. And I want the 7. Let me see. I think I am inside the gallbladder, huh? Okay, ten ahí. Yes. So this is 6.5. Okay, inyecta. Okay, so I think this is the perfect case to use one. Después vos, ¿eh? Tráeme el colonoscopio de 7.5. ¿Cuál es? Ese. C. Okay. So I want to show you today. I think it's a super nice case. Wait. Voy a cortar. I will cut now. I will make my sphincterotomy. It's not the same to see in black and white. I don't know if my good friend Isaac Reichman will agree with me. It's not the same to see in black and white that going inside and see with the camera and then to see if there is any lesion. So I want to see what is going on inside. I think it's very exciting this case. Pero este fue los que yo trajeron. Sí, está bien. Sí, está bien. So this is the 7.5 range. The new 7.5 range cholangioscope from Microtech, right? So one of the big advantage is a very, thin caliber, but the advantage is that we have 1.2 millimeter working channel, like a standard cholangioscope. So we can pass biopsy forces and we can take biopsies, that's all. But also I believe could have a very nice, interesting and probably futuristic clinical application, which is el colangioscopio necesito. La imagen con la angioscopía. So, which is the possibility of the possibility of take a biopsy. Entonces no es. No, no. Este es. Este es. Ese no es. Ese es 6.5. I will change, yeah. Technical difficulties. It's okay. So I will show this one. So one of the difference is this one that you can see here. So you will see in the camera, but we have also a measure in the same catheter. The catheter has improved a little more rigidity, but at the same time flexibility, and is 1.2 and is 7.5 range, which is very good. So this is one of the newest one that is coming, right? I think there is almost 11 cholangioscopy companies doing that. So this is the new IMAX 7.5 range. So thank you Microtech for the opportunity of working with this today. So I think I am showing one of the very nice advantage of this technology and technique, right? And what is the future? Necesito la imagen de colangioscopía en grande. So you can see now. You see? So you have until there 3 centimeters inside, 4 centimeters inside, 5 centimeters inside. So very nice. And now we go with my guide wire. I can start to see neovascularization. No sé si podemos usar la inteligencia artificial. So I will use also the AI. I want, yes, the image, biggest one. Okay, so now we have, this is what we have. So I have a patient with gallbladder cancer, but this is the contrary. I believe this is an invasion from the gallbladder. This is not a cholangiocarcinoma. It's not that the cholangiocarcinoma went and born here and went to the cystic duct. Through the cystic duct, you can see here. Tenemos AI. Look how easy I am going inside the gallbladder by fluoroscopy with this cholangioscope. So I believe one of the possible indication in the future of this one, ponlo aquí. No tienes que abrir ahí. No, espérate. Así, así. I like it. So one, ¿tenemos o no? Sí, ¿no? So quiero que me pongan la imagen del arco en C en grande primero. So that's why, Chris, I was talking to you that I believe this could be a very nice indication in the future for other application. So I'm very excited to start to make some. Sure. I'm alone. So now I'm here. You can see very well. Okay, now I am inside the gallbladder. Saca la guía. So this could make easier to evaluate the gallbladder directly. You can see here. Now I see the epithelium. Now I see what I was looking. You see? So the AI is detecting this lesion as a possible cancer. It's just based on the morphology, huh? Yeah. So this is another level of the future. Of the future of cholangioscopy. As I mentioned many times in my presentation, I think the way to make treatments and more diagnosis and more a lot of things in the biliary tract and the pancreatic duct is with this. So congratulations, Microtech. This is very good. This is a very good product, huh? So I will pass now my fine needle biopsy, and I want to see, you know, fine needle biopsy. No, my biopsy forceps. So I still in the gallbladder, right? So I would say from the wall, from some areas, but also I would say from that part that, you know, that I see when I was going inside. That is in the common bile ducts, affecting the common bile duct right now. So now I know that I am out. No. So now just arriving, easier to pass. You see? Look the lesion. I'm in the gallbladder. Okay, abre. Very nice indication. So it's a perfect indication, you know, if you don't have US and you make a suspicion. So that's why I believe cholangioscopy is abre. Okay. So I'm on defaults for my. So now it's open. You see? So now I will take a biopsy from this area. Cierra. So I'm taking a biopsy from the gallbladder through the cystic duct. So very nice case. Yeah. So I want to invite you to our, you know, live course that will be in August. So thank you so much for the sponsors that will be with us. You can see this white area, huh? No mud, huh? And it's good. It's good to have a very good comparison, and I want to see, you know, what we need to see in the future is better to have biopsy from here. It's better to see, you know, this kind of lesion. I believe we have a lot of questions that we need to see it. This is pus for sure. Now, okay. So you can see here very well. I will remove myself a little bit, abre. Cierra. So AI is showing this, huh? Very nice case. I like it. It's a new kid on the block. This is a new kid on the block. The 7.5 range IMAX. And then we have the 9.8 with working channel of 2.0. I hope to show you soon. Very big expectation, you know, what clinical application we can develop it with these new technologies. You see here the AI is showing us very well where is the problem and when we need to take our biopsies. Now, you see? Okay, now I'm out. Okay, abre. Very nice, huh? Let's take this biopsy from here. Cierra. Let's take another one. Abre. Cierra. Okay, so I take 4 biopsies. I believe I'm okay. So you can see here the lesion. Part of the lesion. This is the area that we saw it, and this is the stone that we saw it also. You see? Oh wow! This is not a stone. It looks like a stone. It's not a stone, huh? Dame una pinza para tomar biopsia de aquí. Yeah, or maybe it's a stone. I'm not so sure. Very nice image. Presta. I will pass the biopsy forces. I want to see what is this. But one of the possible clinical application is to treat the polyps, right, with these scopes, going inside and take the polyps and remove it, and not make that, you know, and change the way that we are doing with the polyps in the gallbladder. We remove the gallbladder because of that. So it's like removing the whole colon because of 2 polyps in the colon. It's something like that. So theoretically and technically it was impossible before, but now I think with this technology we can change many other indications. We can have different indications, new indications. This is very interesting, really interesting. I'm very excited. Ah, la uña. Oh, okay, so abre y cierra. Ahí pasamos. Okay, so abre. I want to take a biopsy from this area. Cierra. Meten ahí. Toma. Very interesting. Look this area. Very interesting. It looks like a stone, but it's not. I think it's my first time that I see a gallbladder cancer from inside. I'm not so sure. Look, it's very different. I think it's amazing case. So I look the quality of the image. Not, I'm not so sure if you are looking the quality of my image. Look at the quality. I want that you see the quality. It's very good. Abre y cierra. Eso. And it's very smooth. The working channel is perfect, Chris. The working channel is perfect. Okay, abre. So I want to go here. Ok, cierra. No, abre. Cierra. Okay. So I will remove slowly. So this is extension. You see the lesion? It's coming here now. So now I'm the cystic duct. You see? Now I'm the cystic duct. So the AI is showing a lot of lesions here, a lot of suspected areas for cancer, and then this is the main entrance, you see? So I want to see the extension here because I remember it was, you see, we start to see here cancer. This is also cancer here. So I want to take a biopsy from here. Necesito una biopsia. So I believe this is not more, a surgical candidate for sure. I really like it. How do you think? I want your comments regarding the quality of the image. I want your comments regarding my regards of the future of application of this technology, right? The 7.5 French. The way that we can make even lithotripsy is amazing, and the way that we can, pass through the cystic duct easier is amazing also. So maybe in the future we will start to treat more, not gallbladder drainage, but directly from the natural orifice. What it means, not through I don't know, one abre y cierra, abre. So this is what I want now. Cierra. Perfect. Okay, listo. There is stones going out also, which is good. So now, you see? So the main bile duct from here, so it means 5 centimeters from the orifice. Now I can measure. This is why I believe this is amazing. Just small things that change a lot. So from the papilla, 5 centimeters inside, start the cancer, you see? And then I can go inside. Okay, let's see. Let's say if I can go, I don't know where I am. Oh, yeah. That is a stone. No, I need to go up. I'm going inside my gallbladder. So this is fibrosis. Dame contraste. Momento. Oh, here. So here is my. It was the cystic duct, huh? Yeah, the cystic duct is okay, but here, look, cancer. So it's a synchronic cancer, and it was not detected by ERCP. Cholangioscopy didn't show it. Cholangiogram. Cholangioscopy showing us now. Now I am. She's. I don't know. I need to discuss with the surgeons, but I believe it's not more resectable. They need to remove not just the gallbladder. They need to remove. I am an 8 centimeters from the orifice, from the ampulla. You see. So these are big data. I think is very interesting even for the surgeon. So we are in the bifurcation. Now you can see my C-arm. It's very smooth. It's perfect, the working channel. The working channel is perfect. It's almost, I believe it's bigger on the 1.2. I don't know. But well, there is, you see a synchronic lesion. And it was not possible to make the diagnosis. Okay. Está fuera. Ahí abre. This is neovascularization. Cierra. Okay, I'm taking biopsy en otro frasco. And I want to go in this way. Here. See? Let's go to make a big exploration now. So now I am in intrahepatic, right intrahepatic So this is cancer. So this is a, there is a, sorry, I freeze it. Uh, this is a, this is extension of the lesion, huh? So no more, no more. That's why I didn't see it like a big dilation. This is still, you know, this is cancer in the inside the biliary tract. So you see, now I am in the right hepatic duct, intrahepatic duct. So no possibilities of una biopsia más tract, right? If there is a resectable lesion, we need to make a cholangioscopy. Why? Because I am starting to see a synchronic lesion, metachronic lesion. How we can say? Synchronic lesions, yes. No, but this is not the invasion. This is outside. This is the invasion of the cystic duct, yes. But this is biliary tract. This is the intrahepatic, right intrahepatic duct. And it's a cancer, you know, appearing in this area. So very nice case. I want to say thank you again. So hope to see you soon. You can see this a lot of fibrotic tissue here. That's why this patient is with jaundice. But there is no obstruction. Huh? There's no obstruction, so I will not put any stent. It's not necessary. It will be a disaster to put a stent, I believe, in this woman. She doesn't have any, you know, stent, nothing. Abre. And now we have this, unfortunately, diagnosis for her. But well, fortunately also we avoid one surgery that is a big surgery with probably, you know, another lesion that is will reappear. That's why I believe the guidelines need to be changed and we need to make more studies. We need to make more studies for sure. Abre. Cierra. Okay, so thank you so much. This is 9 centimeters. I want to see the, you see, this is another area. So this is infiltration. It's coming from down, remember, and this clear invasion. You see, una biopsia más. But this is not invasion. This is a synchronic lesion. Okay. Or metachronic. I don't know exactly how to explain this lesion, but this is a cholangiocarcinoma and gallbladder cancer. So two cancers. I don't know is the same one. I need an explanation from the oncologists. They know better than myself. I need to read about this for sure. So thank you for joining us. And well, I cut my transmission. I will take more biopsies from this area. I like to take a lot of biopsies because, you know, in that way I can avoid another another, you know, okay, abre, cholangioscopy or thing like that. That is not necessary because I am sure that this patient have cancer right now in both areas. Biopsia. You see? Perfect. Now, finish. Okay. So thank you so much. I used all the technology possible to have a very good result. But now we know exactly what we need to do it with this patient. So thank you again. So thank you, Chris, for the opportunity also. Thank you, Microtech, also for the opportunity. It has been a very nice, you know, partnerships. And I want to finish today. So thank you. We cut off.